Hello, everyone. As Dr. Chow mentioned, my name is Muizz, and I'll be doing a presentation on Dopplers. So just going through the objectives, we'll review the background of Doppler and Doppler effect. We'll discuss some of the various Doppler modalities, including, sorry?
Sound like beautiful.
We'll discuss some of the various Doppler modalities, including pulse wave, continuous wave, color, and tissue Doppler. And then we'll review some of the utilization of Doppler and comprehensive echoes through various normal and pathology. So beginning off, we'll talk a little bit about Christian Doppler, who lived from 1803 to 1853. He was born in Salzburg, which is now Austria, to a family of actually stonemason. And he actually first proposed the Doppler effect in a paper that he wrote in 1842, which I'm not going to pronounce, but ultimately translates to on the colored light of the binary stars and some other stars of the heavens. This hypothesis that Christian Doppler developed was then later tested by a gentleman, Muizz, in 1845, where he used sound waves. And it's how we sort of think about Doppler today. He noticed that the sound pitch would change depending on whether the source of the sound was moving towards or away from him. And then there was another gentleman in France by the name of Hippolyte Fizeau, who also independently discovered the same phenomenon using electromagnetic waves. In France, actually, the effect is sometimes called effet Doppler-Fizeau. So what is the Doppler effect? Well, the Doppler effect really is just a change in frequency of a wave due to the motion of the observer or source. In echo, the source of the sound waves are actually from the ultrasound crystals, and the object that we're looking at are the red blood cells and sometimes the tissue or the myocardium. The ultrasound itself emits waves at a fixed frequency that are then reflected back towards the probe by the red blood cells that we're measuring. And if the red blood cells are moving towards the probe, they result in higher frequency waves being reflected back. If they're moving away from the probe, the frequency of the waves is much lower. So we can imagine here, if our probe is observer A, and the spire shrug are red blood cells, and they're moving towards the probe, we see that the frequency of the waves is increasing as it's moving towards the probe. And frequency is really just the number of oscillations of a wave per second. Now, if you imagine that our probe was in the observer B spot and our red blood cells are moving away from us, the frequency decreases. So that's sort of like the basic understanding of Doppler. Now, moving on to the modalities of Doppler that we have. The first and probably most used one is the pulse wave Doppler. So the pulse wave Doppler is able to measure Doppler shifts at a specific point of interest, and this is called the sample volume. The way that it works is that you have a single transducer crystal that sends out a signal at a fixed time interval. The same crystal then waits to receive the reflected signal before sending out another signal. Because of this, there's a maximum frequency of the signals that the crystals can actually send out, and that's called the pulse repetition frequency, or the PRF. This is just an example of what a pulse wave Doppler looks like on echo. We can see that there's the sort of dense outline and sort of hollowed or blacked out interior. The other thing to know about pulse wave Doppler is that by increasing the distance of the sample volume from the probe, you're actually decreasing the pulse repetition frequency, which limits the amount of Doppler shift you can measure. The reason for this is, again, if you think about how pulse wave Doppler works, if your sample volume is further away, it has to wait a longer period of time for it to receive the reflected signal back before it can send another signal. The maximum Doppler shift you can measure is then half of the pulse repetition frequency, which we also know as the Nyquist frequency. And then any Doppler shifts that are above this Nyquist frequency results in aliasing. And aliasing in simple terms is really velocity jets that end up appearing to be going in the opposite direction from where they actually are. I found this diagram to be very useful in terms of actually understanding aliasing and why it happens. So if we look at the the left side of the screen, we see this wheel here that is moving in a clockwise direction. Now, let's say we have this red dot at the 12 o'clock position, and we are able to record samples every quarter turn of this wheel. So every quarter turn, this red dot is going to go here, 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 and we're actually able to record it every second that it moves in that direction. So our sample will look something like this. We can very nicely see that this red dot is going from the 12 o'clock position, 3, 6, 9, back to the 12 o'clock position. So we get a very accurate a visualization of the movement of this dot. Now, this is where, this is what aliasing would look like on the right-hand side, on the right-hand side with this blue dot. So in this diagram, this dot is still moving in, ignore this, this is sort of what we visualize, but this red dot is still moving in a clockwise direction. So every quarter turn, it's going to move clockwise. However, if we're only able to sample this dot every 3 seconds, this dot, after it starts at the 12 o'clock position, is going to look like it's at the 9 o'clock position. And then 3 seconds later, it's going to be at the 6 o'clock position, and then back to the 3 o'clock position. Now, if you ignore this arrow, what it would actually look like to our eye is that this is moving in the opposite direction, because it starts here, 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 here. So you can see how it looks like it's moving in the counterclockwise direction because we're only able to take a sample every 3 seconds. So I found that very, very useful to actually visualize what's happening. Now we'll talk a little bit about continuous wave Dopplers. So continuous wave Doppler really is different from pulse wave Doppler for a few reasons, one of which is how it actually sends and receives signals. So with continuous wave Dopplers, it utilizes 2 crystals instead of 1 like in pulse wave. Because of this, ultrasound waves are sent continuously from 1 crystal and received by the second crystal simultaneously. And because of this, there's no pulse repetition frequency because everything is happening at the same time. So now we can measure high velocities and Doppler shifts. Unfortunately, one of the drawbacks of continuous wave Doppler is because we don't have this sample volume, we can't really determine where along the path this maximum Doppler shift is happening. We just know that along this path, there is this maximum velocity measured. And you can see on the right-hand side how it looks in comparison to your pulse wave, where in pulse wave, we had a sort of dense outline with a hollowed out inside, and continuous wave, what we're looking for is a very uniform and dense signal throughout. I was talking to this about Dr. Chow, actually, and sorry, this is a visualization of what it looks like. So with pulse wave on the left, you have 1 signal, and this is the sample volume, it waits, and then it has to wait to receive the signal back. With continuous wave, all of this is happening at the same time, so it's sending and receiving. So yeah, I was talking to Dr. Chow about this yesterday, actually, and he had a very interesting analogy. He was talking about how pulse wave would be considered a good husband and continuous wave would be considered a bad husband. And the reason for that is is with pulse wave, you're actually taking the time to talk, to your partner, wait for them to respond, and then, respond accordingly. Whereas in continuous wave, it's just rapid fire. You're just continuously aggravating your partner without listening to what they have to say. And, I found that a little funny, to be honest. And then we'll quickly talk about color and tissue wave before we move on from the modality. So with color wave, color Doppler is essentially based on the same principle of PW. Here we have multiple sample volumes along the trajectory that you're measuring, and it's actually able to calculate the specific blood velocity at each of these sample volumes, and then it assigns a color and intensity to each sample volume. The way that it's recorded or coded is that velocities coming towards the probe are red, and then velocities that are moving away from the probe are blue. And we know that as BART, so blue away, red towards is a way to remember this. And then with tissue Doppler, again, similar principle to PW, but instead of measuring the Doppler shift of red blood cells, we're measuring the Doppler shift at the tissue or myocardium level. And this is very useful to assess ventricular relaxation and diastolic function, which again isn't the main purpose of the talk, but this is an example of what it would look like when we are doing our echoes. So now we'll go into sort of the meat of the talk and talk about how Doppler is utilized in our comprehensive echoes. And I just wanted to lay out a disclaimer that this isn't a talk on pathology. So it's not extensive valvular pathology or diastolic dysfunction. It's really more so just a background to give a background of how Dopplers are used in our sort of comprehensive assessments. And there are multiple great presentations already on the SMH Echo YouTube on a lot of these pathologies if you want to go back and look at them. So we'll start with the mitral valve and our pulse wave assessment. So in order to do our PW assessment with the mitral valve, we do it in the apical 4-chamber view. We place a 1 to 3 millimeter sample volume at the tips of the open mitral leaflets, and we want to aim towards the lateral wall because that's distinctly where the blood flow tends to move towards, and then we measure the mitral inflow velocities there. So this is what it would look like if done correctly, and we'll go into a little bit of what this means. So when you get the PW assessment of the mitral inflow, you get the signal, and I know when I started, I was like, what does this mean, and what am I actually measuring? So I'll go through that briefly as well. So one of the things that we want to measure is the peak E-wave velocity, which is corresponds to early or rapid ventricular filling at the start of diastole. So it's useful to look at the ECG to see sort of after the T-wave, which one is the E-wave. So in this case, it's this, and you're measuring the peak E-wave velocity here. Next, you want to measure the E deceleration time, which is essentially the time of this early rapid filling. And unfortunately, there is, but it's very faint. You're going from the peak of the E wave all the way down to the baseline, following a nice slope along that sort of triangle. And then the last thing you want to measure with this PW assessment is the peak E wave. And this corresponds to atrial contraction or the inflow velocities that are associated with that. And in this case, you would generally see that after the P wave. So here, the A wave corresponds to this peak. Now, you can't always obviously use the size of the E and A wave to determine which one's which, because with diastolic dysfunction, you may get a reversal where your A wave is larger than your E wave. So again, it's always useful to look at the ECG. And again, just quickly, the primary utilization of this is to assess diastolic function or dysfunction. And then this is just an example of what things may look like during your assessment. So we kind of looked at normal already, where you have a large E and a smaller A wave. And then again, as I was saying, these E and A waves may look different depending on the type and grade of diastolic dysfunction. So you can see here the E and A wave are reversed, and then again, this isn't a talk on diastology, but you can sort of get different E and A wave morphologies. And then ignore this for now. We'll talk about tissue Doppler in a little bit, but again, all of this sort of works together for your for assessing diastolic filling patterns. So we don't have to wait too long, but now we'll just briefly talk about tissue Dopplers, because again, it's used in conjunction with our PW to look at diastolic dysfunction. Again, similar to our PW assessment, you want to do this in the apical four-chamber view. You place the cursor with the sample volume at the level of the mitral plane annulus at both the septum and the lateral wall, and you're essentially measuring how well it's moving at those levels. So again, this is what it looks like. So we have our septal measurements here and our lateral measurements here, similar to our mitral inflow PW. We have our E and A, but again, we're measuring the tissue movement, so it looks opposite. And again, we have this sort of very dense outline and hollowed out interior, because this again is a PW assessment. Some normal values to keep in mind is that the lateral annulus velocity should generally be over 10 centimeters per second, and then the septal annulus velocity moves a little bit less, and the normal value for that is greater than 7 centimeters per second. And again, it's another measure of diastolic dysfunction. Moving on to continuous wave. So we can look at CW assessments of the mitral valve in both the apical 4 and apical 3 chamber views. With this, we place the cursor through the mitral leaflets, and then essentially what we're measuring is high velocities, either from turbulent stenotic flow that's moving forward or regurgitant flow. So it's not something that's necessarily always done, but if you're wondering about stenosis or regurgitation, it's a useful measurement. And I have a slide here. So I was wondering if someone could tell me what's going on. And again, just a hint, this is going through the mitral valve and a CW.
MS and MR?
Yeah, exactly. So happening sort of simultaneously, or not necessarily simultaneously, but this person has mitral stenosis with some turbulent forward flow, which is indicated by this part of the Doppler signal, and then below that we have our regurgitant flow. So let's say we have some mitral stenosis and we put a CW Doppler through the mitral valve. Again, this isn't always done. It's really only done when we see findings that are consistent with mitral stenosis. These are some of the measurements that you can get with CW in the context of mitral stenosis. So things that you want to measure, or things that you can measure with the signal, is the pressure half-time, or the PHT. Here we're essentially looking at the deceleration slope of the maximum E velocity. It's not used as much anymore, but again, with this signal, it is something that you can calculate, and and with that value, you're actually able to calculate the mitral valve area. So once you get the pressure half-time, you divide 220 by the pressure half-time, and you can estimate the mitral valve area. Again, this isn't an extensive talk on valve pathology, but I know there are some great videos on the SMH echo sort of going through all of this. And other things that you can measure with mitral stenosis with your CW is you want to trace the outline of this dense signal, and this way you're able to obtain a mean pressure gradient as well, which is useful in our assessment of severity of the mitral stenosis. And then let's say we have some regurgitant some mitral regurgitation, and we're using our CW assessment. And what are some of the things that we can measure, and we'll talk about what they mean. So ultimately, whenever we get a signal like this, we want to trace this dense CW signal, and we can obtain the velocity time integral, or the VTI, which essentially corresponds to the flow of blood over time. And it's useful for the continuity equation, where we actually want to calculate the regurgitant volume. I'm not going to go over all of the equations, or again, the sort of in-depth assessment of mitral regurgitation, but again, it's just something to keep in the back of your mind with regards to why we do these assessments with regurgitation, and obviously previously we talked about stenosis. The other useful measurement when we have our CW sort of VTI trace is we can obtain the Vmax, which again is useful when assessing severity. And then finally, something that I've come across during this rotation is the PISA sort of assessment of mitral regurgitation, which again, we'll very, very briefly talk about. So what are you measuring with PISA? With PISA, you're looking at this sort of dome-shaped structure, which is sort of the point of maximum and iso velocity where the defect of the mitral valve occurs. So when we measure PISA, what we're trying to get is this very uniform hemispheric structure where we're able to measure velocities and radiuses to calculate regurgitant flow and regurgitant volume. The way that this works is that we're essentially going to want to change the aliasing velocity, or the velocity where we have this switch in forward and reverse flow, in order to get this sort of perfect dome-shaped appearance. And when we change the aliasing velocity, we can create this concentric hemisphere of high velocity near this regurgitant orifice, or this flow convergence area. And then with this sort of perfectly dome-shaped structure, which isn't always feasible when we do our measurements, we can calculate, or we can get the radius, put it into our equations here, and get our values for regurgitant volume, or regurgitant flow, and regurgitant volume. Next, we'll move on to the tricuspid valve. So with the tricuspid valve, we mainly do assessments with CW. And what we're measuring is we're placing the cursor at the lowest point on the TR jet to obtain the maximum velocity. And normal values essentially is a TR velocity of less than 2.8 meters per second. And the utilization of this is that it can approximate the RVSP, again, if there's no significant RVOT or pulmonic stenosis. This is an example of what that may look like. So again, we go to the lowest point of our dense tracing, because again, remember, this is a CW. What we want to avoid is any sort of fuzzy areas that would overestimate our max velocity. So we want to try to get the point where it's still quite dense. Next, we'll move on to the LVOT. So with the LVOT, the type of Doppler measurement we use is the PW. This is measured in both the apical 5 chamber and the apical 3 chamber. And with this, what we want to do is place the PW sample volume 5 to 10 millimeters proximal to the aortic valve. And that should correspond to where you measured the LVOT in the parasternal long axis view. So again, this is what that tracing would look like. So we can see our sample volume with our double lines here, and this corresponds to our LVOT, which again should be similar to where we measured our LVOT diameter in the parasternal long axis. So what to measure? Well, anytime we get a PW here, we want to trace the largest spectral sample. And with this, we can obtain a few important values, one of which is the Vmax, the VTI, and it will also spit out the mean and maximum pressure gradients as well. Some normal values to keep in mind is that the LVOT Vmax should be within 80 to 100 centimeters per second. The VTI is 50 to 25 centimeters, and the mean gradient should be less than 30 millimeters mercury. Higher than that, and you worry about some LVOT obstruction. And just going back, you can see that again, you want to trace the dense area of this curve and try to avoid some sort of like the fuzzy areas that you may see with the signal. In conjunction to our LVOT, we also look at our aortic valve and sorry, this should say CW, but with our aortic valve, we again look at the similar views, the aortic 5 chamber and the aortic 3 chamber views, and we want to do a CW measurement of the aortic valve. So we place a CW cursor through the LVOT, through the aortic valve, and then the proximal ascending aorta. And this is what that signal would look like. So again, we can see the difference in our CW and PW, where we just have a very nice dense signal through the aortic valve. And now that we have that tracing, what we measure, so again, with similar to the LVOT, we want to trace the largest spectral sample, and we get our sort of similar measurements. So we can get our Vmax there, our VTI, and then our mean and maximum pressure gradients. Here, the normal values are Vmax of 80 to 130 centimeters per second, a VTI of 50 to 25 centimeters, and a mean gradient of less than 5 millimeters mercury.
I think you mixed the pulse wave with the. So the mean gradient in the pulse wave is normally like 3.
Oh, I see.
Yeah.
Oh, yes. All right. Okay. And once we get our aortic valve and our LVOT assessments, we can essentially use this to assess LVOT and aortic valve pathology, again, namely obstruction and stenosis. So by using the continuity equation, we can calculate the aortic valve area, which utilizes the V1, which was our LVOT Vmax, and then our V2, which is our aortic valve measurement. And we can also determine the severity of AS using the aortic valve velocity ratio, which is again using the ratio of our V1 and V2. So that sort of talked about obstruction or stenosis of the aortic valve. What if we have regurgitation? Again, anytime we expect turbulent flow, whether it's stenotic forward flow or regurgitation, we want to use CW measurements. So here we have a nice tracing of what aortic insufficiency or aortic regurgitation would look like with a CW through the aortic valve. And with this, with the aortic regurgitation, again, similar to our mitral regurgitation, we can measure our pressure half time. In this case, the Pressure halftime again is looking at the slope, and really it corresponds to a decrease in half the pressure from the maximum. And we can see that as the pressure halftime decreases, we increase the severity of this aortic regurgitation. So our CW signal ends up looking steeper and steeper. Next, we'll talk about the RVOT assessment. So with this, we start off with our pulse wave or our PW. We want to place the sample volume just proximal to the pulmonary valves in both the peristernal long axis and the peristernal short axis view, where we're optimizing the RVOT. So this is what it looks like, and we'll talk about what this means in the next slide. But you can see that we're essentially trying to measure the steepness of this acceleration time. So what to measure when we get the PW tracing of the RVOT? Again, we like to trace these samples, the one that looks the best, and we can get our VTI, our Vmax, peak, and mean gradients. And we can also calculate or measure what's called the RVOT acceleration time. So that corresponds to this line over here. And we can see that the normal value is between 120 to 140 milliseconds. If you get less than 100 milliseconds for your RVOT acceleration time, that's suggestive of pulmonary hypertension. And with this value, we can actually calculate our mean pulmonary arterial pressure with this equation over here. So some of the normal values for our Vmax with our PW is 80 to 120 centimeters per second, and our VTI is around 18 to 22 centimeters. We can also do a CW measurement of the RVOT by placing the CW cursor through the pulmonary valves and the RVOT, and again, both the peristernal long and short axis view, where we have a clear view of the RVOT. And this is what that tracing would look like. So this is what we expect in terms of a normal CW RVOT tracing. And then we can see a couple of pathologies. So if someone wants to tell me what these are. So we can start with the left, this one here.
Tina, do you think?
Yeah, and then that would make this one exactly. So again, a way that you can sort of look at this is we know our ultrasound probe is here and we're measuring going down. So in this case, the flow going down is going to be related to the flow through the valve. So this is pulmonary stenosis, and then regurgitant flow would be going backwards towards the probe. Next, we'll talk about our hepatic vein. So with the hepatic vein, we use our PW measurement or our pulse wave measurement. And with this, we're placing our sample volume within the hepatic vein in the subcostal view. And this is the tracing that we get, which actually took me a while to understand. But essentially, we get four sort of main waves. We have our A wave over here. We have our S wave, B, and D. So here we have our A wave, S, B, and D over here. And again, we'll briefly talk about what they mean because we do this measurement with every comprehensive echo, and it's useful to understand what we're actually looking at. So with our A wave, where the A wave corresponds to atrial contraction, which in turn increases your right atrial pressure, which causes retrograde flow through the hepatic vein. So we can see that or it's a little hard to see here, but if there's retrograde flow, it's going to move back back up the vein, which is towards the probe, which is why we get a signal going above the baseline. With the S wave, that corresponds to ventricular systole, so easy to remember, which then causes movement of the tricuspid annulus down. That in turn decreases the pressure within the right atrium, which promotes forward flow through the hepatic vein, which is why we get a slope going down, because this corresponds with blood flow down the hepatic vein and towards the right atrium. Next, we get our V wave, which corresponds with atrial overfilling. So as the atria is filling during ventricular systole, you're increasing the pressure in your right atria, and flow through the hepatic vein as a result will slow down, and you may even cause some mild retrograde flow if you have overfilling of the atria. So sometimes this may even be above the baseline. And then finally, we have our D wave, which corresponds with ventricular diastole. Again, easy to remember, D for diastole. And that occurs with tricuspid valve opening, which then causes flow from the right atrium to the right ventricle, and then subsequently from the hepatic vein to the right atrium. So if you think about it that way, it kind of makes sense. You have a bunch of waves here, which again, kind of is a little confusing, but if you break it down based off sort of the A, S, B, and D wave and what they mean, it makes a little, makes a lot more sense that way. And then we'll talk about some pathology with this in terms of sort of when it's important to measure and what are some, somewhat common waveforms we may see that are abnormal. So one of the things that we look for when we measure the hepatic vein PW assessment is for systolic flow reversal. So essentially what that means is that instead of flow going down the hepatic vein to the right atrium during systole, it's going retrograde or the opposite way. So you'll see it above the baseline. So we can see our waveforms here where it's a lot easier to maybe look at the type 3 where we have a little bit more of a dramatic pathology. So here we have moderate to severe TR, and we can see that when we have severe TR, we're essentially having a bunch of retrograde flow through the tricuspid valve back into the right atrium, and then because it's all connected back into the hepatic vein, which is why we end up getting flow going retrograde through the hepatic vein, and why we get what we call the systolic reversal. So we can see it here where our S wave, which we expect it to be going down during systole, is above the baseline here. And that can indicate severe tricuspid regurgitation. And there are obviously different types, of type 1, 2, and 3, but again, this is a comprehensive pathology lecture, but it's just things, again, to look out for when you're doing this assessment, because it's something we do all the time with our comprehensive assessments. And then we'll finally talk about the aorta. So with the descending aorta, we can do a PW measurement in the suprasternal view. Here we're placing the sample volume just within the descending aorta, and it should look something like this. So again, the reason why it's below the baseline is because you expect blood to be flowing down the descending aorta. And unfortunately, I gave it away, but I was going to ask you guys what this shows. But this is showing aortic insufficiency, again measured on our PW, where we get hollow diastolic flow reversal. where we end up with this flow above the baseline, indicating aortic insufficiency, because as we said, we expect flow to be going down the descending aorta, and it should be going below the baseline. Because we have in diastole flow going above the baseline, indicating that it's moving towards the probe, we assume it's because of aortic insufficiency, because flow is moving backwards at that time. And next, we'll look at the abdominal aorta. So in the subcostal view, we also use our sample volume within the abdominal aorta, and we can get a tracing that looks like this. So in this case, we have flow moving towards the probe normally. So in this case, we have a PW tracing above the baseline, and this is what a normal upstroke would look like. And then here we have a couple of pathology that I have left blank. So let's see if you guys know what it shows. So again, let's start with the left-hand side. We can see that there's a slow upstroke and continuous flow in diastole. Yes, yeah, and we'll talk about why that happens, but yes. So again, in diastole, you would not expect continuous forward flow, but you're getting it here, and this is consistent with coarctation of the aorta. And then what about the tracing on the right-hand side, where we get this diastolic flow reversal? Yes. So yeah, coarcation of the aorta on the left, and then aortic insufficiency on the right, where we get our diastolic flow reversal. And Dr. Chow and I were kind of discussing why the continuous flow reversal happens in diastole. So Dr. Chow knew this obviously, but he wanted to confirm with ChatGPT, and so we asked ChatGPT, and essentially the reason why this happens is because you get a development of collateral circulation, which then promotes ongoing forward flow even during diastole, in order to bypass this constriction. So I believe that is it. These are some of the references. And yeah, we can, if you have any questions or discussion, we can talk about that.
So thank you, Muizz, for a very good comprehensive review of a very basic topic, yet very important, about the image quality, where to measure the limits, and some of the normal and abnormal findings. It's actually very important because, you know, as we all keep learning and as we're doing, you know, it's nice to actually have a review. It's also a good introduction to anyone that is new to the field. I just want to quickly clarify my analogy of CW and PW, which I had for a long time. So here's how it works. In physics, in ultrasound physics, there's a concept called duty factor. It's how much time that a pulse is actually sent and how long you spend in waiting and listening. So a good husband is like a PW, where you speak very little. So you send off a pulse, and then you spend the rest of the time actually listening all the time to try to locate. And so a good husband is you speak very little and you listen a lot. CW, not necessarily a bad husband, but it's just that you just keep talking and you keep listening. So whether you're listening the right things or not, and